pregnant throughout that time, the sex hormones, because of course, you're not gonna ovulate during your pregnancy. You're not gonna have a menstrual cycle during your pregnancy. All of those surges of FSH and LH, that stops during pregnancy. So it's very important. We always ask and we talk to patients about when they had their first child, how many children they had, how many times they've been pregnant. All of those things are important from a GYN perspective when we're talking about cancer, and also from breast cancer perspective.
Standard or, it had to be 10 months or more?
Well, it's just, they're just saying they carry full term, and we got we get every day possible, like from the point of conception to the first period they missed. Now, they stop having those surges in the hormone. So now you got all of those months that they've been pregnant, that they don't have those surges in hormones, and every one of those months actually is considered to be protected. It's considered to be protected. So the bilateral oophorectomy, prior to age 40 is something that also, it decreases the risk, because as I said, the ovaries are where the pre and perimenopausal women, they produce all of their sex hormones. So you don't really see the sex hormones active in any patients who have had an oophorectomy. They have very small amounts in the adipose tissue, as I talked about. Other than that, it's very low. It doesn't matter if they're 35, if they had an oophorectomy, you treat them like a menopausal patient. And you get oophorectomies for a few reasons. One of the reasons you get oophorectomy is if you have a BRCA mutation. You have BRCA mutations, which moves us down to genetic factors. BRCA mutations actually increase the risk of breast cancer, prostate cancer, and of course ovarian cancer. Yeah, so BRCA mutation is very, very important. So you see the BRCA1 and the BRCA2, both of them increase the risk of breast cancer and prostate cancer and ovarian cancer. So patients get their genetic screening and they have a BRCA mutation, we will make recommendations to for them to possibly get a total mastectomy on both sides, a bilateral total mastectomy, and possibly a bilateral oophorectomy. Okay, and a bilateral oophorectomy, of course, removes the ovary specifically. The fallopian tubes, which of course are connected to the ovaries, you can actually get cancer there too. So a lot of times we may remove everything. But there's also the conversation about fertility. If the woman is wanting to at some point think about, like a lot of times fertility comes into play, they may want to freeze their eggs. There's multiple things that go into that. But the ovaries definitely being removed is beneficial and protective for breast cancer as well as ovarian cancer, obviously, especially if they're a BRCA mutation. So family members, just understanding that we always talk about first degree relatives increasing the risk, but even if you have second degree relatives or relatives that have been diagnosed with breast cancer, like at a younger age, all those things actually increase the risk. So we can usually associate breast cancer with about 10 to 15% of any patient being diagnosed, and we're gonna be identify somebody in their family. And the closer the relative is, the higher the risk of developing breast cancer is. So yeah, breast cancer in your family, that's why the genetic screen is important, but just making sure you maintain and are getting your mammograms at the scheduled times, as that's very important to protecting you and diagnosing it early. Because as we talked about, 5-year overall survival, when it's locally diagnosed, is 98%. It's not until it becomes metastatic or it's distant growth that we start talking about low levels of survival and high levels of progression. So I mentioned the oophorectomy and a prophylactic total mastectomy that can be done bilaterally. Chemo prevention. So chemo prevention brings us to our first drug that I introduced when we first started class. This was in the endocrine therapy section, and it was a SERM. Okay, so tamoxifen is one of your very, very important drugs for patients who have a high risk of developing breast cancer, and we want to treat them preemptively as opposed to waiting for them to show up with ductal carcinoma in situ or lobular carcinoma in situ, which are like precancerous lesions that are formed on the breast that we know can have a high risk of developing to invasive breast cancer. So first thing up, when you see chemo prevention, you should write tamoxifen there. And then you should also write relaxin. Okay, so what's relaxin? Y'all talk about that one? Hmm? That's also a SERM. It can be used for osteoporosis. It can also be used for patients who have a high risk of developing breast cancer, as long as they're postmenopausal. So the studies were done in postmenopausal women. So we have relaxin and we have tamoxifen, a selective estrogen receptor modulators. And just for your information, it's not standard of care, but you can actually use aromatase inhibitors in this situation also. They've done studies with chemoprevention with aromatase inhibitors. But the gold standard is going to be to offer the patient typically raloxifene or tamoxifen depending on their menopausal status. Tamoxifen for pre or perimenopausal patients, raloxifene for postmenopausal patients who are at high risk for developing breast cancer. So now let's talk about tamoxifen and raloxifene in reference to toxicity. So what toxicities do y'all know about SERMs in general? And then what toxicities do y'all know about? So hot flash, definitely, endocrine therapy, hot flash. Okay, what else? So next to tamoxifen, make sure you understand that tamoxifen increases the risk of number one, VTE. So you should always think about thromboembolic events when you think about tamoxifen. You should also think about cataract development, okay? So these patients can develop cataract. Patients can also get endometrial hyperplasia. 1% of patients who are getting endometrial hyperplasia can actually develop all the way into endometrial cancer. So when you see some disclaimers about tamoxifen and endometrial cancer, it's really endometrial hyperplasia. That's what you're gonna see very, very commonly. But then the endometrial cancer is that's a very low percentage of that happen. But the endometrial hyperplasia is definitely something that can occur. So, of course, it also has a host of drug interactions, so you need to be very mindful of what CYP2D6 drugs are on board. Even CYP3A4, you have to be mindful because this drug is biosynthesized by the cytochrome P450 system into its active metabolite. So you want to be very mindful of tamoxifen specifically in drug interactions. Now, tamoxifen is one, raloxifene is down the other. So raloxifene can still cause the VT, the cataracts are essentially almost non-existent. The endometrial hyperplasia, also non-existent with raloxifene. The hot flashes are definitely still there. Somebody said raloxifene can be used for osteoporosis. So on your bones, there's actually estrogen receptors on your bones. Okay, so selective estrogen receptor modulators, they're antagonistic estrogen receptors in certain areas and they're agonistic in certain areas. So raloxifene actually has an agonistic property of estrogen receptors on the bones. Okay, this molecule is agonistic on the bones as far as estrogen receptors are concerned, which is important, which is why it's actually beneficial in osteoporosis. Tamoxifen also has some of those properties. So when I start talking about the aromatase inhibitors, which I'm not gonna talk about it yet, but when I talk about the toxicity, you're gonna notice there's gonna be a lot of focus on the bones. But with the SERMs, they're actually either agonistic, or either slightly agonistic or agonistic if you're talking about raloxifene. One key to raloxifene, make sure you mark that down, raloxifene can only be used in prevention. It is not approved for treatment. Tamoxifen is approved for treatment. Raloxifene is only approved for prevention.
Prevention
Of patients who have high risk of breast cancer.
Question, did you say tamoxifen was also used for, did you say pre or post menopausal?
Pre.
Or did you?
So tamoxifen is used for pre, peri, or post. So tamoxifen can actually be used in all menopausal states, but raloxifene is limited to postmenopausal. Alright, so let me see if I can pull this up. So this NCI breast cancer risk assessment tool is synonymous with the Gale model. So you see it, it's called the NCI breast cancer risk assessment tool, but it's really based on something called the Gale model. So this breast cancer risk assessment tool, essentially, any patient, if you have certain information about their patient, you can assess their 5-year risk of developing invasive breast cancer. So we'll do this on our newly diagnosed patients in the clinic, pretty frequently, just to get not a newly diagnosed, but any patient that has suspicion or has high risk already. Like, let's say they come in and they had a first degree relative that had breast cancer and they were diagnosed at 45. So we'll do a risk assessment on them real quick just to see where they are. So some of the questions that will be asked, they don't wanna know if the patient has LCIS or DCIS history. The reason why is because this model is not validated in those patients. Those patients are already at very high risk of developing breast cancer because they have precancerous lesions that have already been verified. So if you say yes to that, it's gonna stop you, so you have to say no to that. Also, BRCA1, BRCA2 mutation. I already told you how high risk you are if you have a BRCA1 or BRCA2 mutation, where you're at such a high risk at that point that we'll offer you surgeries to try to prevent you from developing cancer later on in life. So of course, if I say yes to that, it's immediately gonna take you off of this tool. You're already above the threshold as far as risk of developing breast cancer in 5 years if you had a BRCA1, BRCA2 mutation.
Is that what it's called, a triple negative?
No, triple negative, we haven't gotten to that point yet, but triple negative, focuses on HER2, estrogen, and progesterone. Yeah, so it's focused on those 3 aspects in reference to breast cancer. Now, asking the patient age, so we'll say the patient is, we'll say they're 45. You notice the lowest it goes is 35, because that's the lowest. The youngest patients in this pool of patients that validated this study or this model were 35. So the older, the younger than 35, the model doesn't work on. Now, at one point, the model didn't work on African American women. It was actually only this whole patient pool was focused on Caucasian women at that point. But they gathered more and more data, and now there's a validation and there's a comfort level in reference to estimating risk of African American women also with the Gale model. So here's another thing. So biopsies that actually were performed, they actually are detrimental or increased risk because there's tissue that's been damaged that then needs to be healed. So if you have patients that have multiple biopsies, that can increase the risk of them developing breast cancer also. So we'll say this patient did have some biopsies. They don't want to know how many they have. We just say they have one. The more I add as far as the number, the more the risk increases. Okay, so then let's talk about it. Once they had their biopsy, let's say it was benign, but let's say they had a patient that had some atypical cells. They weren't cancerous, but they were atypical, meaning they were growing kind of in a malformation. And we already talked about this. We're looking at the patient's age and when their menstrual cycle first started. So, can y'all explain to me why this is important? So the patient is 7 to 11 and they start their menstrual cycle, what is that saying?
More exposure to hormones.
Increases their risk, right? And why does that increase their risk?
Because they're more exposed to
They're exposed to the hormones for 3 additional years, 4 additional years, 5 additional years, okay? So that, I'm gonna say our patient, essentially had a average, onset of their menstrual cycle. Now, what's this question? What does that mean? Why is that important? What's the number? 30. Okay, so if you had your first child after 30, it's considered to be protective or it's considered to be risk? It increases your risk, okay? You'll say 30, okay? Now this will put you over the top, but I mentioned that like 10 to 15% of cases can be directly linked to women in their whether it's their sister, their mother, their daughter, somebody else is a first relative and also had breast cancer. So I'm gonna say no to not just shoot this patient completely over the moon in reference to their 5-year risk. But if I said one or if I said two, all of this progressively increases their risk as they get more and more first degree relatives. Okay, so they came back, the average risk for a patient is 0.9%. Their risk at 5 years is 1.9%. I did this model to show you that if any patient is above 1.7 or at 1.7 or above, then we will offer them that chemo prevention I was talking about with the raloxifene or the tamoxifen. We use this tool, and this is the tool that was used in the clinical trials to assess a patient's risk to see if they were an appropriate candidate to get the 5 year, the 5 years of tamoxifen or the 5 years of raloxifene. And what kind of patient do you use raloxifene in?
Postmenopausal.
Okay, that's correct.
Dr. Hunter,
Talk to me.
so if you're a woman and you're going in for a mammogram
Mhm.
and you do all that assessment,
Mhm.
and so I guess if they meet the criteria more on the increased level,
Mhm.
you would do like a prophylaxis treatment or no?
So you say if you do the Gale model, any woman does it, because you can see anybody can do the Gale model, a woman can do that on her own. That's open to everybody. If you're above the age of 35, you can perform the Gale model. If you perform the Gale model, you answer the question accurately, you're above 1.7% 5-year risk. Once the tool has assessed all of your risk factors, then you could go into a PCP with that data, and they should feel comfortable prescribing you raloxifene or tamoxifen depending on your menopausal status.
Okay.
So these prognostic factors, not necessarily something you need to commit to memory. The only one that's important is actually this one right here, Key 67, which is the proliferation rate of cancer cells. As you get more and more lymph nodes, it causes patients to be at higher risk of developing metastasis. Grade 1, 2, and 3, if it's a grade 3, the poorly differentiated cancer is more prone to metastasizing as well. And the reason I mentioned the Key 67 is because of our CDK4/6 inhibitor, which one is that? Brand generic. What is that? Verzenio is the brand name. Verzenio is the brand name.
Yes.
Verzenio is the brand name. Abemaciclib is the generic. Okay? So CDK4/6 inhibitors. The Key 67 is actually important because that cellular proliferation rate needs to be above 20% for the patient, number one, to qualify to receive the Verzenio. So the way the Monarch E trial was completed was that they assessed the Key 67 being above 20%. You also want a patient to have lymph nodes that were positive, and they looked at the size of the tumor and the grade of the tumor. So grade 3, you see, is poorly differentiated, and that's also a prognostic risk factor. Okay, the size of the tumor, whenever it's above 5 centimeters, that's also a poor prognostic factor. So 5 centimeter tumor, that's considered the biggest that we can pretty much grade on a T&M staging system. It's considered to be a poor prognostic factor. And the Key 67 being above 20% is also a poor prognostic factor. That means the cells are proliferating at a higher rate. So that's why I say that's one of the more main things that's important, understanding that the higher the Key 67, the faster the tumor growth and the more aggressive they tend to be. So patients who are qualified for abemaciclib in the adjuvant setting, they need to have a Key 67 that's above 20% and have lymph nodes that are positive, and then the grade 3 disease, and possibly having large 5 centimeter tumors. Now, hormone receptors, HER2 new gene amplification. This is what makes a patient triple negative versus triple positive versus HER2 positive, HER2 negative, and hormone receptor positive, and then also, of course, like we talked about, the triple negative. It's not your job because you're not a pathologist. I understand these things because I work in, of course, I work with breast cancer patients the majority of my career. But, understanding that we do always assess the HER2 status of a patient, and we do also assess the hormone receptor status of a patient across the board. Every single breast cancer patient have this information. If they don't, then you're making a decision on incomplete information. You need to know the hormone receptor status, and you need to know the HER2 status. Okay? So Adjuvant Online is an important, these are like tests, and like when you get deeper into breast cancer, I don't think they're as important, but they're worth mentioning. The Adjuvant Online is a tool that we use for patients who are hormone receptor positive to see how beneficial it may be for adjuvant therapy. The same thing with the Oncotype DX, which is a 21 gene assay. The only one that's really mentioned in the guidelines is the no negative Oncotype DX test. This one is important because we use this when a patient could possibly get only endocrine therapy versus get chemotherapy and endocrine therapy. And if their Oncotype DX risk recurrence score comes back high, then we're gonna tell them they may benefit. It might only be 3%, it might only be 5%, but it might affect their overall survival if we give them chemotherapy on top of the endocrine therapy. So the Oncotype DX is a 21 gene assay that really just assesses a patient's risk of recurrence from getting chemotherapy versus only getting endocrine therapy. Because if they're hormone receptor positive, they're always gonna get endocrine therapy. It's just if they're gonna get chemotherapy. Does that make sense? Or you want me to repeat that?
Please repeat.
So when you're talking about the Oncotype DX test, it's looking at a risk recurrence score. So it takes 21 genes, it's the same 21 genes for every patient. And the compilation of those genes can help us assess the risk of a patient's recurrence if they don't get chemotherapy. So if they don't get chemotherapy, they're only gonna get endocrine therapy. So if they only get endocrine therapy, maybe their risk, throw out a number, is 20%. But if they get chemotherapy, maybe it'll go down to 17%. So you're looking at a 3% benefit, and you talk to the patient about all the toxicity and the risk associated with chemotherapy, and you let them make their decision. But the higher that score, the higher the percentage of chemotherapy benefiting that patient. Okay? All right. So most of the time, you see over 90% of patients, they're just gonna come in with a lump. And that's why and it's gonna be painless a lot of times. So that's why it's very important, the breast self-exams. They've always had a conversation about how important it is to do the breast self-exams. Is it even beneficial for the patient, so on and so forth. I've had a lot of patients, I'm not gonna say every patient, but I'm gonna say at least 20 to 25% of patients, the breast cancer was identified by them first. So they were the first person to notice the lump. And the reason why that's important is because if they don't notice that lump, maybe they go another 6 to 9 months when they're into their next mammogram for us to find the lump. And we find the lump, instead of them having maybe stage 1 disease, maybe they have stage 3 disease because they've been sitting on tumor that's been growing for 9 months. So the breast self-exam is important to catch the lump as early as possible to let us get you in and get treatment now versus later. So that's why the breast self-exam is very important, because of the painless lump being the first usually manifestation. Everything else that I'll talk about here is uncommon because it's more related to more advanced disease, like the nipple discharge, the retraction of the nipple, dimpling. Sometimes patients have dermatologic changes on their actual breast, which is indicative of inflammatory breast cancer. So there's like a lot of different types of things that can happen to patients, but it's more in the advanced stage. First stage, painless lump. That's where you want to get diagnosed, at painless lump. Okay? So, of course, I talked about patients either getting or having an early stage, which is very important, or at least having it localized. You want to stay away from the advanced and distant metastasis. And like I say, 60% of patients will usually present with that very advanced disease. So we're expecting to diagnose 94% of our patients with stage 1, 2, or at the worst, stage 3. We don't expect very many of our patients to come in with metastatic disease, although I have patients that come in with metastatic disease. So I have them, but we would prefer if you came in with stage 1, stage 2, or stage 3. we expect to knock you out the park essentially. We give you chemotherapy, you get your surgery, we have you on a very aggressive survivorship program, and you live a longer, healthy, happier life. Okay? Now, the different types of breast cancer, DCIS versus the LCIS, the reason I have the greater than syndrome there is because DCIS has a higher propensity to develop an invasive breast cancer compared to LCIS, which is lobular carcinoma in situ. You can have cancer in the ducts, or you have in the lobes of the breast. Those are like the two major places you really see it at. That's why you have ductal and lobular. Only thing about diagnosis to understand is we always need to do a biopsy. You can't, even if you identify a patient has the lump, but they have this consistency that may be consistent with breast cancer, we want to always do a biopsy. And we are going to go ahead and do ultrasounds, MRIs as adjuncts to sometimes identify patients who need a biopsy. You should have saw it at the top there, not necessarily something you commit to memory, but patients who don't want to get a bilateral total mastectomy, they may opt for getting breast MRIs. So instead of just getting a regular mammogram, they get an MRI on an annual basis to get a better imaging of their breasts and any hyperdensities that might end up showing up that we need to biopsy to identify if they are actually breast cancer. These are some screening guidelines. Of course, the screening guidelines get a little bit different depending on which governing body you look at. But I always err on the side of the NCCN guidelines because they have the most robust therapeutic guidelines. But if you remove one of the other ones, nobody can necessarily argue with you. But you see that the clinical breast exams being able to start annually at age 40, mammograms start at age 40, but this is always for average risk patients. But when you get to the patients who have higher risk, I mean, you can be as young as 25. I have a patient that got diagnosed maybe like 2 months ago that was 28. So it's not like everybody's gonna be diagnosed at 40. That's just like the average. So you have family members, or you have genetics, there's other things that can put you in your mid to late 20s, and you truly can't be diagnosed because I have these patients that, you know, I mean, not to scare everybody, but we're in college and actually found out from the physical they had to get for college that they had a lump, and then that's what started the whole process of them finally getting to the cancer center to be treated. So if you have high risk, you have genetics, some of those things can possibly cause you to put you in that space where we want you to start getting your clinical breast exams at age 25, and you know, usually nothing before age 25, but definitely 25, you can start doing it if you're at high risk. And these are just some numbers in reference to the prophylactic things that we possibly do with patients. So, because it's driven by hormones, if we do the bilateral oophorectomy, the lifetime risk decreases by 50%. And of course, removing your breast altogether decreases your lifetime risk by 90%. So we have patients with bad genetics or patients who have a host of family members that have developed breast cancer at younger ages that are first-degree relatives. These are things that you can offer a patient. And I have seen patients that go through both of these because especially when you talk about the oophorectomy, if you get the oophorectomy because you have a BRCA mutation, remember the BRCA mutation not only increases your risk of developing breast cancer, but also ovarian cancer. So if you get your ovaries removed, you protect yourself from two cancers that are especially ovarian cancer, is very hard to treat in women. It's a lot harder than breast cancer, and the mortality and morbidity is much higher. We won't go very hard on these because we actually discussed these already, but those trials that I was talking about with tamoxifen and raloxifene, this is just the data associated with those trials. These are those trials I was describing. So prevention, postmenopausal women, raloxifene. Tamoxifen, pre, peri, and postmenopausal women. And remember the Gale model, 1.7% being the 5-year lifetime risk that we really worry about. If it goes above that or is at that point, that's when you qualify for getting these chemo prevention. Okay, so now let's get to some treatments. So I mentioned right now y'all talked about the selective estrogen receptor modulator. Okay, so we have tamoxifen, we have raloxifene. And what kind of patient are you using it?
Tamoxifen,
Tamoxifen is what? Pre, post, and peri. Peri, of course, is in the middle, like usually those patients are gonna transition into menopause within maybe 2 to 3 years, that's the time we give them. Okay, and that's usually patients that are in their mid to early 50s that are considered to be perimenopausal. We can do tests, to detect on certain levels, which we can estimate that. Now, let's talk about aromatase inhibitors. So, what other drugs that I talked about in the endocrine therapy portion, besides aromatase inhibitors, have we not talked about? Yeah, I got y'all list of drugs that we started with, right? We had our chemotherapy, we had our HER2-directed targeted therapy, we had our checkpoint inhibitor with our PD-1 inhibitor, pembrolizumab, and then we talked about endocrine therapy. We had aromatase inhibitors, we have selective estrogen receptor modulators, and what else do we have?
You can use progesterone.
Which one?
LH.
LHRH agonists. Okay. So what do those do? How do they work?
They increase the amount of hormones, like luteinizing hormone, initially, and then decrease it dramatically after that.
What axis does that target? Y'all know what that axis is called? The HPA.
Oh, the pituitary.
It's the hypothalamic pituitary axis. Okay, it works by a negative feedback loop. So the LHRH agonist, which is goserelin, okay, or leuprolide, we have pre and perimenopausal patients. If you want to use an aromatase inhibitor, you have to use it together with the AI. So the AI and the LHRH agonist, they go together. Okay, they go together. All right. Okay. Let me see if this thing will work. I might think so. Okay. Okay. So tell me those 3 things that we need to check on for patients who have breast cancer. You need to know their hormone status. And what else? Okay. So let's go, first of all, with endocrine therapy. So that means they gotta be positive, right, across the board. Okay, they got, if you wanna do endocrine therapy, they have to be hormone receptor positive, okay? So, when I say selective estrogen receptor modulator, what do I mean? We're talking about treatment now. And remember, we're focusing on stage 1, 2, and 3 patients. We're not gonna talk about stage 4 patients, because that would add about 60 other treatments. So we're just focused on stage 1, 2, and 3. Say somebody said tamoxifen. And what about AI? What are we talking about? Mustang is actually also there, but we really use that in the metastatic setting. And then LHRH agents.
Glutamine, Leuprolide.
Leuprolide, yep. This is goserelin, and this is leuprolide. Zoladex is goserelin, Lupron, and leuprolide. So when you have patients who have hormone receptor positive disease, you're gonna use at least one of these 2, and this possibly is gonna be added on. And it's directly related. How do I make that decision? How do to make the decision if I wanna use these two together, or this one by itself, or this one by itself.
They're menopause.
Okay. So now we have our three patients. We have a premenopausal, perimenopausal, and a postmenopausal patient. The premenopausal patient, we can use tamoxifen by itself, or we use an AI plus an LHRH agonist. And a conversation that ensues very frequently is how long. So, rule of thumb is just say 5 to 10 years. There's data using tamoxifen as much as for 10 years. Most of the data with AIs is 5 years. But you know that the endocrine therapy has to be as long as at least 5 years. That's minimum. It should be a minimum 5 years, and then it can go up to 10 years if you're using tamoxifen. Now, you talk about premenopause, pre and perimenopause, it's the same thing. So what I say here goes here also. What I say here, it goes here also. Postmenopausal. So now postmenopausal, I can use tamoxifen or an AI. And there's no need for the LHRH agonist. There's no need for the LHRH agonist. So does anybody have any questions so far? Does this make sense? This is stage 1 through 3.
So no relaxant, post,
No relaxant. Where's relaxant in?
yeah.
No, she just asked me that. She said no relaxant in post, and I said no. And then I asked you guys, where's relaxant?
It's more for preventative status.
It's for prevention. Remember, Gale model 1.7% 5-year risk, prevention postmenopausal, not for treatment. Any questions so far right here?
Miss, can you explain the pay for free?
It's spurring the premenopausal.
Yeah.
So premenopausal, you can do tamoxifen for up to 10 years, or you can do an aromatase inhibitor like a anastrozole or letrozole plus an LHRH agonist like leuprolide or goserelin, but you have to use them in combination. Do y'all remember why we had to use them in combination? In the pre and peri? It goes back to the mechanism of action I was talking about with the drug. So where is the estrogen and the sex hormones made in in postmenopausal women?
In adipose tissue.
In the adipose tissue. Postmenopausal, right? In the premenopausal women, where is it made?
Ovaries.
Ovaries. Okay? So it's made in the ovaries in the pre and perimenopausal, and it's made in the adipose tissue and the postmenopausal. If we want to use an aromatase inhibitor, the aromatase inhibitor's site of action is where? Mainly in the adipose tissue, okay? If you wanted to decrease the activity of estrogen progestin in a pre or perimenopausal women, you need another mechanism of action in reference to the drugs. That's why you need the LHRH agonist, to shut down the hypothalamic pituitary axis, and that's targeting the ovaries. So the LHRH agonists essentially target the ovaries, and the aromatase inhibitor is doing all of essentially the adipose tissue and all the other miscellaneous areas where you may get small amounts of estrogen. But the amount of estrogen stoppage from the AI is not adequate for pre and perimenopausal patients by itself. In contrast, tamoxifen is an agonistic and an antagonistic estrogen receptor modulator, depending on what area we're talking about, throughout the body. Okay, so anywhere where there's an estrogen receptor, if it's antagonistic there, it doesn't matter how much estrogen is circulating, it's very effective in blocking that activity at the breast specifically. Just like it's agonistic at the bones, and you don't have to worry as much about what I'm about to mention right now, which is osteoporosis. So with the aromatase inhibitors you need to make sure the patient has some type of bone modifying agent and you're monitoring their DEXA, especially in these types of patients, postmenopausal. So they need some type of bone modifying agent. So what do y'all know about bone modifying agents? What's a bone modifying agent? Give me one. That y'all see very frequently. Bisphosphonates. Okay, so give me some bisphosphonates. Alendronate, residronate, abandronate, zoledronic acid. Okay? Is there any other type of drug that would fit into this bone modifying agent class? That's not a bisphosphonate? Denosumab. Y'all know what that drug is? Prolia. Okay, so Prolia. So the caveat and the ones I want you definitely to leave today with is a drug called Reclass and also Prolia. Reclass and Prolia, Reclass is zoledronic acid, Prolia is denosumab. And the dosing of these agents and the frequency of the dosing is important because it changes when you're using it in a patient who's got osteopenia or osteoporosis secondary to taking endocrine therapy, specifically AIs, in postmenopausal patients. Now, those two drugs, if I change the branding on them, they could be used for metastatic solid tumors. So patients who have metastasis in their bones, you can use those same chemicals, but it's a different dose and a different dosing frequency. But right now, Reclass and Prolia is what you're gonna add to your part. Okay, Reclass and Prolia. So does anybody have any questions about endocrine therapy right now?
You put stage 1 to 3 for the.
Everything we're essentially talking about is stage 1
1
to
to
3.
3.
In reference to endocrine therapy. Yeah, in reference to endocrine therapy. I'm about to throw something else in there, but right now we're talking about stage 1 to 3. When you're talking about the aromatase inhibitors compared to the SERMs, you need to be mindful that the aromatase inhibitors cause myalgias and arthralgias, and then I just talked about the osteoporosis and osteopenia associated with them. And this is really challenging in postmenopausal patients because they don't have that exogenous estrogen and sex hormones that's flowing in their body that's gonna strengthen their bones. They get a substantial drop in that, and it already causes their bones to be brittle and weaker. Yeah. And then when you add the fact that I'm gonna give you an antagonistic estrogen drug, like for instance an aromatase inhibitor, then you're increasing that risk of osteopenia, osteoporosis even more. Okay, so can we leave this remotely? So now, I'm specifically talking about stage 3 patients who are hormone receptor positive and HER2 negative. So who's this guy?
Verzenio.
Which one?
Verzenio.
Okay.
You know.
Abemaciclib. Okay, so abemaciclib in stage 3 patients who have hormone receptors that are positive, hormone receptors that are positive, HER2 negative disease, and they have lymph nodes that are positive. What else might they have? What else did I talk about earlier?
Dr. Hunter, you can erase that if you need to.
Oh, it's over here?
Yeah.
You had the cash up there, so I left it alone.
I'll take it. I'll write it later.
Stop this.
I appreciate that.
Okay, 5 centimeters, lymph nodes that are positive, what else? Well, it's grade 3. The patient's in stage 3, but it's grade 3 that's poorly differentiated, so that's considered one of the poor prognostic factors. What's the most important one that I talked about? Everybody has to have this if they're gonna qualify for abemaciclib therapy. That's stage 3, that's hormone receptor positive, HER2 negative. What is that?
1.7.
Okay. Alright. So they got lymph nodes that are positive. Gotta have this. You gotta have this. And then these two depend on the amount of lymph nodes that are positive. You gotta incorporate this. But they need to have lymph nodes that are positive. They need to have a key 67 score that's above 20%. And then they qualify for abemaciclib. Okay?
And
And
this-
abemaciclib can be used
This is
in
kind of-
combination with anything that's going on here.
What is that?
Anything that's going on here. So it doesn't matter if they're pre, peri, or post-menopausal. If they meet that criteria up there, then you can use your endocrine therapy that I've already taught y'all in combination with abemaciclib. Times 2 years. So they got 5 to 10 years of endocrine therapy, and they got 2 years of abemaciclib. So y'all know any side effects or toxicity associated with the CDK4/6 inhibitor? So neutropenia is one. It's not the main toxicity of this specific one, but it is about 40 to 45% of patients get some form or grade of neutropenia with abemaciclib.
Diarrhea.
Diarrhea is 90%. Okay, so abemaciclib, you should think diarrhea before you think anything. It should be diarrhea followed by neutropenia, and then the other ones are kind of sprinkled in there. But you always need to think about diarrhea, neutropenia. Just in general, they have a box warning of interstitial pneumonitis. They also associated, what'd you say? It's a box warning for interstitial pneumonitis, like pneumonitis, there's like, the patients can get inflammation in the lungs when they're on abemaciclib. But the diarrhea is in the trials, in the registry trials, about 5% of patients discontinue therapy because of diarrhea. That's the most common reason why patients have problems with this particular drug. Which is followed by patients having the neutropenia. So how do y'all feel about endocrine therapy?
So are we adding the abemaciclib when the patient, qualifies for that?
If they got the key 67 that's above 20% and they have lymph nodes that are positive, it's a conversation to start having with them about adding abemaciclib that's appropriate in that patient.
Just that, adding it to other things?
You're adding it to either tamoxifen, or you're adding it to aromatase inhibitor, LHRH agonist, or you're adding it to aromatase inhibitor by itself, possibly the postmenopausal.
So adding it to just one of them?
Just one, yeah, just one. Okay. So any questions about this before we leave and we go to the chemotherapy part? Not sure, I'm about to erase it.
We got it recorded.
Oh, okay. Alright,
What?
say what?
She wants a picture.
Hmm?
She wants a picture.
Alright, well. So with all of these are really going through this in stages. So you look at the stages, whether you're stage 1 through 3, there's essentially gonna be surgery, but the endocrine therapy follows the surgery. So the endocrine therapy follows the surgery in the stage 1 patients. Now, when we get to stage 2 and 3, the endocrine therapy still follows the surgery, but then we get to our next conversation, which is chemotherapy. So we're about to talk about chemotherapy now, which really focuses in on the patients who are stage 2A and 2B. Okay. Alright, so now, we talked about everything related to endocrine therapy for these type of patients, and we've knocked out CDK4/6 inhibitor. So now we've got chemotherapy left and targeted therapy, and we have checkpoint inhibitors. Okay. We have checkpoint inhibitors. So, on one receptor positive, and we'll say HER2 negative. We're talking about chemo. All right, so definitely your standard is dose dense, AC, followed by weekly Taxol or dose dense Taxol. Okay, so if you look at the end of the hand, that actually there's a list of all the different chemotherapy regimens. So this is one of those that's included on here, but this is probably one of the more important ones to make sure you know. Okay, I got all of them on there from the guidelines, but this is one of the most important ones to know as you leave. So the AC, does anybody know what the AC stands for? So it's adriamycin actually. It isn't anthracycline, but it's adriamycin, which specifically is doxorubicin. So this is doxorubicin and this is cyclophosphamide. Does anybody know what the difference between, why do I say dose dense AC and not just AC? Do y'all know what the difference between one versus the other one is? No. Okay, so dose dense AC is every 2 weeks versus conventional AC is every 3 weeks. Same dose, but every 2 weeks versus every 3 weeks. Does that make sense? So the doxorubicin is 60 milligrams per meter squared, and the cyclophosphamide is 600 milligrams per meter squared. This is named stage 2, 3. So 60 milligrams per meter squared of adriamycin, 600 milligrams per meter squared of cyclophosphamide. When we're talking about dose dense, it's every 2 weeks. When we're talking about regular AC with no dose density, it's every 3 weeks. It's the same dose. It's the same dose, it's just a different frequency. So dose dense AC is every 2 weeks, okay? Dose dense AC is every 2 weeks. Conventional AC, where I can say AC, that's every 3 weeks. Same drugs, same dose. Okay, weekly Taxol versus dose dense Taxol. So weekly Taxol is as it appears, okay?
Excuse me,
Sure, talk to me.
so if you're saying there is some dose of that, what do the numbers represent on the 600?
60 milligrams per meter squared is the dose of the doxorubicin. 600 milligrams per meter squared is the dose of the cyclophosphamide in both regimens. 80 milligrams per meter squared is the dose of the paclitaxel given weekly within the weekly Taxol regimen, And if you give it a dose dense Taxol, which is coincidentally is every 2 weeks, it's 175 milligrams per meter squared. So how much chemotherapy do we have left now? How much we got left? I gave y'all a certain amount of drugs, how many of them do we have left now? Y'all went too far already. Taxotere, which is dose of Taxol, okay, and we have carboplatin. Those are the only two I haven't touched per se as of yet. Okay, so right now, we got Dr. Rubinson in the building, we got Taxol in the building, and we got cyclophosphamide in the building. Every 2 weeks for dose dense, every 3 weeks for conventional AC. Weekly Taxol versus dose dense Taxol, which is every 2 weeks. Now let's talk about toxicities. Anthracyclines. What's one of the top toxicities?
Cardio.
So we have to get an echocardiogram for every patient prior to them starting anthracycline. You have to get an echocardiogram prior to starting anthracycline for every patient. Okay. Y'all know what happens when a patient arrives at their lifetime dose, which in Dr. Rubenson's case is typically documented as 550 milligrams per meter squared. So A, you wanna make sure you remember the lifetime dose of Dr. Rubinson, that's A. B, if you go above that lifetime dose, you get a logarithmic increase in congestive heart failure incidence. So whenever you have a patient is went above that 550 milligrams per meter squared, now they're getting a logarithmic increase in their congestive heart failure risk secondary to anthracycline exposure. Okay? No? Does that make sense?
So what's the?
So you said a lifetime dose?
550 milligrams per meter squared. What'd you say?
The lifetime dose again?
550 milligrams per meter squared.
Okay, and the one after that? You said be above that
If
dose?
you get a logarithmic increase, logarithmic, you know logarithms? So it goes from 1 to 10. So it goes from like a 1 to 10 times the increased risk, 100 times the increased risk. You see what I'm saying? Every time you get higher and higher in your dosage after 550 milligrams per meter squared.
The logarithmic increase.
Increased risk
Let's see,
See, I had enough today.
Yes.
I exploded. I don't know.
Can we get like some practice questions,
Go above.
Dr. Hunter?
Yes.
Can we get like some practice questions?
Go to a practice question.
Yeah.
Well, I mean, I really,
Like upload them later?
I mean, I really haven't,
He gave it,
I still kind of need to teach y'all a little bit more for y'all to be able to, for y'all to really be able to, but this is what I do, okay, how about this one? This is what I do.
AOC?
I mean, you know, them, I give you the AOC, it's not a problem.
You do, it's basically cardiotoxic.
Alright. Still need more of those people, but we gonna, I'm gonna use this case to try to teach for the.
Yeah. And then it increases longer.
Alright, let's look at this case again. Okay, so this is a 70-year-old white female presented to the medical oncologist from a referral from her PCP. She has abnormalities on her right breast, okay? There, as far as the mammogram is concerned, and they've done some pathology on it, and they noticed after they do the core needle biopsy that there are some cancerous cells there. She got a past medical history of ovarian cancer, and she's she's also had a total abdominal hysterectomy with a bilateral sarcophago oophorectomy. Okay, so she, you see her medication there. You see that she has, I can tell you she has stage 3 disease, but you guys don't necessarily have to know how to assess that. It's not your job, especially not at this point in your career. But she has a T3 tumor, which if you guys recall when I was speaking about abemaciclib, if they have a tumor that's 5 centimeters or above, it's considered to be T3 disease. Okay. She also has N2, which means she's got the nodal status of 2. That typically means they have more than 4 lymph nodes that are positive. Okay. So she would actually be a good candidate for something that we talked about, right? But I'm missing one thing. What am I missing? To possibly give her that, I'm missing a few things. I'm missing really just one thing. The key 67, okay? Also, you look, so she got grade 2 disease, not grade 3. She is ER/PR positive, and she's HER2, and the IAC with the immunohistochemistries is 1+. 1+ is not considered to be HER2 positive. You have to be 3+. Okay, you have to be 3+. I will on the exam though clearly differentiate if the patient is HER2 positive versus HER2 negative. So you won't have to be able to assess the IAC scores, but I can tell you that 1+ is not positive. It's a low amplification, but it's not amplified enough for us to qualify her for HER2 directed therapy. And you don't have to worry about the amount of cells. It could be 25%, but still gonna treat it the same way. But this patient has like an overexpression on a lot of the invasive cells are HER2 positive, or HER2 negative, hormone receptor positive. So, with this patient, she's 70 years old. See, I think she's pre or postmenopausal. Post. Okay, she's post. So what are her endocrine options? Or what else?
Relax, no, tamoxifen, just tamoxifen.
Aromatase inhibitor.
Tamoxifen or AI. Tamoxifen or AI. She can get either or. Okay. However, what do we need to make sure we do with her in reference to the endocrine therapy? And how long is she gonna get the endocrine therapy? And what toxicities are you gonna talk to her about? If it's an aromatase inhibitor, we do 5 years. If it's a selective estrogen receptor modulator like tamoxifen, we can do up to
10
what? 10 years. The data is kind of met in the middle where you'll see the clinical practice guidelines, 7 years is sometimes mentioned. But we always do more than 5, and typically they can't make it to 10. So if y'all wanted to do tamoxifen, what are the toxicities y'all would talk to her about?
Myalgia,
Bone marrow.
osteoporosis.
Myalgia with tamoxifen or with the aromatase inhibitor? The myalgias and arthralgias are associated with the aromatase inhibitor. The endocrine, the endometrial hyperplasia is associated with tamoxifen.
BTE.
The BTE is associated with tamoxifen.
Cataract.
Cataracts are associated with tamoxifen. Hot flash is associated with tamoxifen as well as aromatase inhibitor. So you can put that particular toxicity across the board with the endocrine. Now, still, are y'all gonna try to use tamoxifen or y'all using aromatase inhibitor?
Tamoxifen.
Okay, you gonna use tamoxifen. So here's something that we hadn't talked about, and I had like more chemotherapy regimens than I was talking here. Maybe we'll pick it up on Wednesday when y'all not, when y'all ain't so cooked. So patient arrives in the clinic. This type of patient, usually stage 3 patients, we're gonna treat them neoadjuvant. And what does that mean?
Before,
Chemo.
Before surgery. Before surgery, okay? So before surgery, because if we treat them before surgery, the outcomes are actually better. A lot of times the patient will get a complete pathological response before they even get surgery. The chemotherapy pretty much has gotten rid of anything that's identifiable with the cancer. We still would end up taking the tissue, possibly taking a whole breast in somebody who had a tumor of her size with lymph nodes that were positive. But the chemotherapy up front, it's like it gets rid of micrometastasis. So you gotta think about chemotherapy being a systemic treatment versus surgery being a local treatment. You need both of them to truly cure the patient. So we would neoadjuvantly And because at this point, I've only taught y'all one chemotherapy regimen, I guess we're gonna have to use this one, okay? So we use dose-dense AC followed by weekly Taxol. So one thing we had talked about was the fact that the dose-dense AC is times 4 cycles. Okay, dose-dense AC times 4 cycles. The weekly Taxol is times 12 weeks. The every 2-week Taxol is times 4 cycles. Okay. So neoadjuvantly, what we did with this patient is, we gave him 4 cycles of dose-dense AC, followed by 4 cycles of dose-dense Taxol, and then they had surgery. They got the whole right breast removed. They got the total. Whole thing, okay? However, you'll see, in the handout that radiation, and it's the only thing you have to know about radiation. Radiation, there are just a few reasons you get radiation. So she's gonna get radiation because she has lymph nodes that are positive. If you have lymph nodes that are positive after you get the surgery, you always get radiation. If you have positive margins, you also get radiation. If you get a breast conserving surgery, you also get radiation. Another name for breast conserving surgery is a lumpectomy. The positive margins, do y'all know what I mean when I say positive margins? So positive margins is when the surgery has occurred and the surgeon has suboptimal resection of the tumor, and there's tumor at the edge of the resection area. So they left a little bit of it there, and this indicated the patient needed radiation if that happened. So now, y'all gave them chemotherapy, they got surgery, they got radiation because they had lymph nodes that were positive, and then finally, y'all chose to do tamoxifen. Tamoxifen can actually start right after the surgery. So the tamoxifen is there too. We'll say times 7 years. In this particular case, this is a complete therapy for this patient. They would give 4 cycles of dose-dense AC, followed by 4 cycles of dose-dense Taxol, followed by a total mastectomy, followed by radiation and tamoxifen for 7 years, and just for chokes. We'll say that Q67 for 25%. We'll give her abemaciclib times 2 years with the tamoxifen. And that is the answer to that case. One of many variations of the answer, but it's one of the answers. Yes?
Why is the tamoxifen 7 years instead of 10?
It can be 5 to 10 years, but we pretty much try to get them to 7. So there's data saying that 7 is just as good as 10. Yeah, so 5 to 7 is 5 to 10 is what you're gonna see in literature, but the news data will say that 7 is just about as good as 10. So if we get them to 7, if they wanna stop it, we let them stop, unless they're highly motivated to continue. Yes?
So, would you start with the surgery and radiation, and then you do the treatment like that, or does it?
In this patient, we typically employ neoadjuvant therapy. So neoadjuvant therapy means that the chemotherapy is gonna go before the surgery. You could do the surgery first and then do all of this after the surgery, but that's not the standard way we practice in current time. Yeah, surgery usually is done first in early stage patients that aren't gonna get systemic chemotherapy. So stage 1 patient is gonna get surgery and then probably endocrine therapy. If they're stage 1, they're not gonna qualify for abemaciclib, but they'll get endocrine therapy. And then what test would we maybe run on a patient like that who wouldn't qualify for abemaciclib, who had hormone receptor positive or HER2 negative disease that was stage 1? We talked about it. Think about it. Now, the key 67 is talking about the proliferation. Remember, we talked about the Oncotype DX, that 21 gene assay is for a stage 1 patient who's hormone receptor positive, HER2 negative, who doesn't have any lymph nodes that are positive. So no lymph nodes that are positive, hormone receptor positive, HER2 negative, you do Oncotype DX, and you can get the risk recurrence score. You can make that decision if you just want to do tamoxifen, or if you want to do chemotherapy before the tamoxifen. Yes.
With the patient's age and the adverse effects of tamoxifen, would you prefer using an aromatase inhibitor instead?
Yes. But if you say tamoxifen, you're not wrong. If you're asking like, in this patient, this specific scenario, we typically would go away. We really don't like to use the selective estrogen receptor modulator, to be honest with you, especially in postmenopausal patients. But there's data to say that it's perfectly fine, the efficacy is definitely there. Unless the patient has been through the aromatase inhibitors and they complain mightily about the myalgias and arthralgias, and we're kind of out of options, and we may be able to switch them to tamoxifen. But we're typically gonna come out of the gate with a postmenopausal patient with an aromatase inhibitor. That's why I asked y'all which one y'all wanted to use. But remember, if I use the aromatase inhibitor, I also did have to add another drug on. Then I would have expected y'all to tell me that the patient needs to be on a bone modifying agent, like abandronate or residuinate, okay? Or even in more extreme situations, Prolia or Reclass, which are like injection infusion. So do y'all have any other questions about today?
In terms of the bone modifying agent, how do you determine, it doesn't?
Which one?
Yeah.
I mean, they actually have some data saying that zoledronic acid has some superior data that's come out, being used every 6 months in adjuvant treatment, these types of patients. But Prolia had been our gold standard, like it had the best data for the past 3 to 5 years. But now, when I say Reclass versus when I say Prolia or zoledronic acid versus denosumab, we kind of use them interchangeably, and actually we've been using more zoledronic acid, as recent data has shown that it's beneficial in adjuvant patients from a therapeutic perspective. The denosumab is more expensive than the Reclass. Denosumab is a monoclonal antibody. The bisphosphonates are cheaper than the monoclonal antibody. And sometimes that comes into play when we start talking about insurance issues.
Where it says surgery or, what does the R stand for?
Just the right, she had right
Oh,
breast
right.
cancer. She had right breast cancer.
Okay.
Okay. All right, I'll see y'all on Wednesday.
Thank you, sir.
They like, please stop.